Hi, today we are about to discuss regarding tracheostomy tube. So what is tracheostomy? Tracheostomy is a surgical creation of an external opening in the trachea. So the indication of tracheostomy for airway obstruction due to laryngeal edema, such as upper airway, congenital, and acquired, like for example, if patient is undergoing anaphylaxis. Foreign body obstruction or a tumor, failed intubation, cardiopulmonary or neurological impairment requiring prolonged ventilation support. Complications: airway obstructions from improper placement of the tube or mucus plugging, hemorrhage, edema, perforated esophagus, subcutaneous or mediastinal emphysema, aspiration of secretion, tracheal necrosis from cough pressure, infection, dislodged tube, or accidental decannulation. Contraindication: if we have the Raines coagulopathy, the coagulation profile like INR is high, then patients receiving anticoagulants, receiving as heparin or clexane, anatomical anomaly or short neck. Initial assessment. What are our initial assessment within 24 hours of post-tracheostomy? So we have the frequency of monitoring every 15 minutes for first hour, every 30 minutes for the next hour, hourly for the next 4 hours, and 4 hourly for the remaining 24 hours. What are we going to assess? We will assess for number 1, signs of respiratory distress and vital signs. 2, patency and integrity of tracheostomy tube and sutures. 3, bleeding and swelling over the stoma site and suture if the suture is in situ. Emergency equipment to keep at the bedside. What are the emergency equipment we need to keep at the bedside? Number 1, we should have sterile tracheostomy dilator. Then 2, spare tracheostomy tube. 1, same size with the tracheostomy the patient is on, and 1 smaller size. Suction set. Then suction catheter and Yanker, and a manual resuscitation bag and oxygen. How we care this tracheostomy, the stoma. Number 1, prepare equipment. Perform hand hygiene and wear an appropriate PPE. Wear non-sterile gloves to remove all dressing at the stoma site and assess the condition of the stoma for redness, swelling, and bleeding. Use aseptic technique to clean around the stoma and under the tube flange with gauze and normal saline. Wipe only once with each gauze and apply new tracheostomy dressing on dry stoma. Clean the site daily and as needed. Suctioning. We need to prepare equipment, have PPE, normal saline, sterile gloves for the open system suction, and non-sterile glove for the closed system suction. Now, what is the closed system suction? The one that we use in ICU, closed system. So we will not use sterile gloves because it's sterile. Then pulse oximeter and vital signs monitoring device, suction catheter. And what is the appropriate suction catheter to be used? So in the policy, we have this formula on how to check or use the proper size of tracheostomy. So tracheostomy size tube multiplied by 3 divided by 2. For example, we have size 8 tracheostomy size. We need to multiply it by 3. So it is 24 divided by 2, 12. 12 is the appropriate size to be used for the size 8 tracheostomy tube. Then suction set. First, hyperoxygenate the patient. Then set the suction pressure to 80 to 100 mm of mercury for adult. Suction depth 11 to centimeter approximately. Then suction every 30 minutes for the first 2 hours post-operatively or as needed maximum of 10 to 15 seconds. Intervention for accidental removal. What are you going to do if your patient has this accidental decannulation? First, assist the patients and maintain the airway using tracheal dilator. Contact immediately ICU physician and respiratory therapist. Only trained staff will insert a new tube if the stoma is more than 7 days. In ventilated patient whose tube cannot be inserted, occlude the stoma and bag the patient via face mask. So what are you going to do? Occlude the stoma with the sterile gauze and then complete the incident and accidental report. So this is how you care the tracheostomy tube. Tracheostomy change, surgical stoma, 7 to 10 days by the surgeon who performed the stoma and tracheostomy team. If it is percutaneous, after 20 to 30 days by the otolaryngology. Then head and neck surgery, physician and tracheostomy team. For the routine, to be done by the tracheostomy team. Uncuff tracheostomy tube with inner cannula every 3 months. Referral to the tracheostomy team to be done by our main responsible physician. So that is how we care for patients with tracheostomy tube.